for inviting me to this lovely meeting, and I welcome you to Egypt. It's going to be a very short talk about Cholerasis. Neonatal cholestasis in cystic fibrosis is known to be rather a benign condition, or rather its course is genuinely easy to cope. It passes within 3 to 4 weeks and it's over. What is the problem here? Why do neonates with cystic fibrosis and cholestasis? Why did I choose this topic? Because I came across 2 cases that I found extremely interesting, and I wish to share the information with you. This child, he's a boy. He presented by jaundice, and he developed it by the age of 7 years. And then he presented to our clinic by the age of 2 months with exceptionally deep jaundice. It was 19, and then within a week it became 25, the kotb. The child had no history of delayed passage of meconium. He had clay stools, and then he had failure to thrive. His weight was only 3.5 kilograms, despite being born with foot term with 3 kilograms birth weight. His length was 56, there was no organomegaly. His total bilirubin was 19. The gamma GT was high, and the ultrasound revealed contracted gallbladder. This very much goes with biliary atresia. Liver biopsy was done, and it revealed marked intracellular and canalicular cholestasis, diffuse multinucleated giant cells. The picture was that of the neonatal giant cell hepatitis. The cholestasis jaundice deepened by another 2 weeks. It became 25. The bile acids were almost normal, and the gamma GT was ever increasing. We did a metabolic screen. It was negative. It was not galactosemia. It was not tyrosinemia. It was not urea cycle defect. The boy developed poor feeding, and by the age of 3 months, the mom said that he aspirated, and that she had to go to take him to the ER, and he was admitted for 7 days in the pediatric ICU, and then he was discharged. He was given olive oil as a choleratic and as a source for his long-chain fatty acids. It was added to his feeds along with fat-soluble vitamins and water-soluble vitamins. The jaundice regressed steadily and resolved completely by the age of 7 months. The diagnosis was very peculiar. What would cause this clay-colored stools and very high gamma GT, which kept increasing? And then it resolved by olive oil, which is a choleratic. What is this? Maybe it's progressive familial intrahepatic cholestasis type 3? Maybe. He had no history of diarrhea or anything. By the age of 7 months, he had a cough, and the child was admitted by a chest problem. And then he stayed something like 5 to 7 days in the hospital, and then the child is 4 kilograms at the age of 10 months. And then he's so weak, he had severe hypotonia, the normal CPK, normal EMG, normal nerve conduction, and the mom reported giving antidiarrheal medicine twice without advice, 2 trivial chest infections. The second time when he was admitted, he echo was done, and it revealed mild pulmonary hypertension. By the age of 10 months, he's still 4 kilograms, there's no jaundice, no diarrhea. He never tasted salty upon kissing. And then his whole exome, we did it because we were looking for a progressive familial intrahepatic cholestasis. And then he proved to be cystic fibrosis child. He had a homozygous pathogenic variant. I looked up this variant. I didn't find in the spectrum of the literature that they don't have, they all have bronchiectasis, they all have chest problems. This was not what we found. This second child, this girl developed pneumonia by the age of 1.5 months. She was breastfed, and she was admitted to the hospital, and then she was discharged. By the way, there was no history of delayed passage of meconium, no diarrhea, no anything. By the age of 5 months, she presented to the hepatology clinic because of 1 week duration of cholestasis. And then, maybe 1 week later, by examination, upon examination, she had hepatosplenomegaly. Maybe 1 week later, she had liver cell failure. The prothrombin time exceeded 1.9. She had massive ascites, she had lower limb edema. When we come across children during the first year of life with acute liver cell failure, we have to look for metabolic causes, we have to look for HLH, we have to look for tyrosinemia, for gestational autoimmune liver disease, but we do not ever consider cystic fibrosis. It is not even part of the, this is not a presentation. Anyway, a week later she developed a fever, and then she had, it was complicated by secondary hemophagocytic lymphohistiocytosis. Her total bilirubin was 7.9, diet was 2.5, her INR was 1.9, her fibrinogen was low, ferritin was high, and it kept increasing. Albumin was 2.1, she had massive ascites, lower limb edema, and then we were looking for an infection, and it proved to be CMV. Her triglycerides were 783, alpha-fetoprotein was 200 times. She received gencyclovir and vitamin E, fat-soluble vitamins, vitamin C. She was offered breastfeeding, continued on breastfeeding, and olive oil as a choleratic again. The parents refused aggressive treatment for HLH, they refused steroids, they refused any aggressive management. They said, she's dying, we don't even want her to stay at home, to stay in the hospital. So we offered her, please come 3 times a week into the clinic, at least. Because we provide the gencyclovir for the children and then the valgencyclovir later. And then her condition improved steadily over 1.5 months. No liver cell failure, no jaundice, hepatosplenomegaly is still there, no diarrhea, very mild symptoms of chest problems. And then she has Bardo failure to thrive. Her weight is not, she's not improving. So we asked for a whole exome. And then she's another child with cystic fibrosis. It's very disappointing that we don't have the sodium chloride in sweat, and it's not really readily available, but it is. Okay. Of course, both cases were referred to the cystic fibrosis clinic to follow with Dr. Maggie and her colleagues. But these 2 presentations were shocking, because this is not the typical clinical picture of when to suspect cystic fibrosis. They never come with liver cell failure and HLH and a life-threatening acute episode like this. The learned lessons: neonatal cholestasis associated with cystic fibrosis may be very aggressive. It may be complicated by liver cell failure and secondary HLH. Chloresis by olive oil was effective in resolving the cholestasis in both cases with cystic fibrosis. So why did we advise olive oil? Why did we? This is something very different. No, at the time, we were having an MD thesis for the nutritional value of olive oil in cholestasis, because children who have cholestasis, infants during the first year, who will not resolve, they will be candidates for liver transplantation. And unless their weight is achieved by 10, they have to achieve 10 kilograms to be suitable for the transplantation. So we were just doing olive oil as an adjuvant. And then it had marvelous effects. We found that maybe I can try something. I'm sorry. We found that 93% of those with biliary atresia resolved the cholestasis. This is exceptional. We never hear of this. We never hear of this. And then in neonatal hepatitis, 93% result, test result cholestasis. We do not see this. And then we revised the literature more, and then it is well known that olive oil shortens the transit time, it increases the gallbladder contraction, the Chloresis, and so forth. Back to our slides. In our practice in hepatology clinic, Cairo University, across more than 25 years, across more than 1,400 neonates and infants with cholestasis, we always get the same picture. Those who receive ursodeoxycholic acid, they have very, very poor results in resolving the cholestasis. And those with no ursodeoxycholic acid, they have a better chance. I know that ursodeoxycholic acid was in vogue for a very big while in cystic fibrosis. Now systemic reviews are revoking the idea. Actually, in more than 1,500 children, we never found ursodeoxycholic acid effective. Hence, it was amazing to find children, both cases resolved on olive oil. Maybe it's high time we studied as a choleratic. UDCA is deleterious, and I did not come and present any data of the older children with cystic fibrosis that I followed previously and who developed cholestasis. Actually, ursodeoxycholic acid was not effective, and they decompensate even before we reach the eligibility for liver transplantation. I think it's interesting that they responded to olive oil, and I'm very pleased that they made it and they're diagnosed, and they will receive the proper management and nutrition. And I hope to see both cases achieve their weight, because the lung affection was minimal. So I think that they have a chance. And thank you very much.
Thank you, Professor Berger. Thank you for always trying to push the natural therapeutics, whether it's honey or olive oil. So what's the source of olive oil? Is it any olive oil or pure olive oil?
Right.
And can we taste some?
Okay, because this was a study at pediatric at Cairo University. We chose the extra virgin, the cold compressed, and what we noticed that the acidity, the children, the neonates cannot tolerate the acidity. So you have to choose something with less than 0.8% acidity. What we found, yes, it is written on the bottles. What we discovered is that a lot of the very low birth weight formula all over the world, they contain olive oil, and it was stunning that many centers abroad use this for the babies and the newborns because during cholestasis you cannot absorb fats easily. So we give them medium chain triglycerides. The medium chain, they can be burned and provide energy, but they do not get incorporated as myelin sheath or brain or anything. So we were thinking at the time, giving them olive oil would provide them with long-chain fatty acids that would allow them to have healthy brains and myelin. We never thought it would have such a great effect on Chloresis. It was a lovely surprise. I loved the surprise.
Thank you, Dr. Meg.
The dose we start with 2 cc's per every 3 hours, and then we titrate them until they reach 10 cc's. Every 3 hours, with the breastfeed, or actually with the artificial feed, or she gives them with the syringe, or 2 cc's to be titrated to 10. Every 3 hours. But quiz, we don't know, because this is a pilot study. We don't know. We have little answers.
I just want to say that it's a pilot study.
Yes, it's a very pilot study. It's a pilot, but it needs to be studied case control. Yeah, this was a case control as well, because it needs to be studied as a choloretic, not as a nutritional supplement. Do you get the difference? And the other problem is, at many times they discontinue in the biliary atresia group. Olive oil did not achieve any result if it gets discontinued. It needs, yes, you have to continue all the time. I'm not sure when to stop, but you allow the mothers after the child is fine, there's no organomegaly, he's achieving the weight, why not stop it? Or at least lessen it, yeah.
Okay, I have a question, and it's for you and Stacy and Amy at the same time. It's quite interesting to me, of course, because this is a very nice non-pharmacologic nutrition intervention, and these are, of course, very nice. Patients with CF by default have fat malabsorption. So my question is, you're giving an oil, which is a fat, and they're getting better, but they do have malabsorption. So how does all of this work?
I kept asking both parents about the diarrhea they didn't have. But cholestasis has a serious issue with the interior hepatic circulation. So the liver has limited capacity, and then it keeps throwing bile into the intestine, and the bile acids and the bile salts and the detoxified material. And then every time this transit time gets longer, you reabsorb. You can reabsorb up to 80% of the detoxified material. And then the liver has to do the homework again and again and again. And then they say the more frequent you pass stools, the more you get rid of these detoxified material and you lessen the work on the liver. Hence they call it cutting the interior hepatic circulation. And I think that I did not go with the
medical induced steatorrhea.
It's not a steatorrhea because actually they don't have diarrhea. I don't know, I have no answers. I don't have answers.
The more you know, the more questions
yes,
you have.
This is intriguing because this is, it's very intriguing. Yet I want to say something. Even in neonatal cholestasis before this, we used to encourage the mothers to breastfeed because we tell them jaundice is bilirubin that will pass in stools. So the more frequent passage of stools, the faster you rid yourself of this jaundice.
Do you have any Michigan experience with natural recipes?
So, for the first question about using the oil as like a nutritive part. So was that patient pancreatic sufficient or insufficient?
We didn't do the elasticity, we sent them.
Okay.
After
so
they were diagnosed,
I was going to say, kind of
They didn't know they were CF. Was accidentally discovered CF taking olive oil.
You would think that it should be pancreatic insufficient, but if they were sufficient, then maybe that's why you're not seeing greasy stools. That's a possibility, and depending on the amount that you're giving to it, you start enzymes. Let's say it's an enteral fetus, and they get to like 20 mL. So it might just not have been enough. That might be that too, to cause symptoms. Fat malabsorption doesn't necessarily present as fat coming out. Sometimes you don't see it, sometimes you just smell it. So hard to know without knowing what their pancreatic status was. We have tried MCT oil as like supplements in our kids just to help with growth, because essentially you don't need enzymes, right? But it has not been the magic bullet at all. And I don't know why. Regular olive oil, canola oil.
Medium chain triglycerides, they are burnt, they become energy, but they cannot build.
Yeah.
So you don't get a brain, you don't get a myelin.
There you go. Yeah. Essentially.
A lot of literature say they're beautiful, but
everybody wants to put our kids on medium chain
triglycerides.
Medium chain triglycerides too. I know.
They
don't do what you think they do.
But I want to say something. Even the olive oil didn't get them to gain weight. I mean, it resolved the
Yeah.
cholestasis.
So, but if those kids were that malnourished, they were probably so catabolic that they probably needed 50 times that just to get them to gain weight, right? So it's not just that problem.
They
So-
were already on infantrini and
Right. And then
junior and things like this.
the ursodiol, that's what you're talking about, right? Yeah, it doesn't do anything.
Very bad.
Yeah, so we have a few kids on it, but we defer, so I was like, never.
Do that never.
But they talked about it at conference about why that's not such a good thing to use, or it doesn't have the effect.
Thank you very much. Thank you very much, Dr. Zach. And I would honored to present Professor Dr. E.U.P. She's actually an editor at E.U.P. She's a leadership and an